Well, ladies and gentlemen, the topic for this afternoon is malformations of the outflow tracts. To begin to understand malformations in the outflow tract, it's useful to review the normal anatomy of the outflow tract, both in the right ventricle and also in the left ventricle. If we take a normal heart, as we have here, and look at it from the front, we can see that the pulmonary outflow tract, here being the anterior descending coronary artery, so we have the pulmonary outflow tract coming up here into the pulmonary trunk, and it points up in this direction. From the left ventricle, on the other hand, we have the aortic outflow tract behind here. This is the aorta, and if I put my probe down into the left ventricular outflow tract, you will find that the two ventricular outflow tracts cross each other in this fashion. So if we look at a heart from the front, we see a crossing over of the outflow tracts. The pulmonary valve being the more superiorly situated valve compared to the aortic valve. But what is supporting the pulmonary valve? If I take the probes away and look closer at this specimen here, we see the pulmonary valve. We can't quite see the pulmonary valve, but I can open up the pulmonary trunk to look down the right ventricular outflow tract, and we can peel off the pulmonary infundibulum away from the frontal aspects of the ascending aorta. Here we see a cleavage plane between the back of the pulmonary trunk here and the front of the ascending aorta. And we also see the left coronary artery taking origin here, and down here is the origin of the right coronary artery. But what is quite interesting, but not very well expressed in anatomical textbooks, is that the pulmonary valve is raised above the mass of the heart, being supported by a sleeve of musculature called the subpulmonary infundibulum. And I'm trying to cut away this subpulmonary infundibulum to show that we can actually remove this structure without entering the left ventricle. But I can do that by taking the scalpel and going round the pulmonary outflow tract, here being the anterior descending coronary artery. And we cut through the fatty tissue first, and to the front of the right ventricle, and we can continue all the way round. So here we have it, the pulmonary infundibulum removed, the aortic root, if you like, here, just sitting over the outflow of the right ventricle. We have taken away the subpulmonary infundibulum, but we have not entered the left ventricle at all. Instead, we have a piece of musculature here representing the inner heart curvature, which separates the right ventricle from the aortic sinuses here. Coming back to the subpulmonary infundibulum, here we have the structure here. It looks like a sleeve of tissue, and you might even be persuaded that it has a ring-like appearance. But if I open up the pulmonary valve, we can see whether there is actually such a thing as a pulmonary annulus or ring. I take my scissors to it and cut through and lay the pulmonary valve open. We can see the scallops here, 1, 2, and 3 of the pulmonary valve leaflets. And you will note that the entirety of the pulmonary valve is supported by musculature here. The attachment of the valvar leaflets is in semilunar fashion, arranged like this, with the low point and a high point at the level of the peripheral insertion of the commissures to the arterial wall. So when we talk about a ring, either referring to the pulmonary valve or the aortic valve, we do not have a conventional ring that can be conceived like a wedding ring, for instance, but instead we have scallop-like arrangements of the valvar leaflets across the ventriculo-arterial junction. The scallops cross the ventricular arterial junction along in that fashion, part of it passing through to be attached to ventricular outlet musculature, and part of it attached to arterial wall. And in so doing, we have 3 triangles between the valvar leaflets that form the interleaflet fibrous triangles. There's one here, there's one there, and there's another one which I have cut through on continuing onto the other side of the valve continuation. So hence we see that in the pulmonary valve we have a subpulmonary infundibulum. And when we were looking at the right ventricle, when I took this valve away, there seemed to be a huge chunk of muscle separating the pulmonary valve from the tricuspid valve. We'll now look at what this piece of musculature represents. So I move on to another heart. We have here a heart with the right ventricular free wall removed, just to show the inlet portion, that's the septal leaflet of the tricuspid valve, apical portion, and the outlet portion. Outlet portion showing once again the complete subpulmonary muscular infundibulum. But on this side, we have the musculature separating tricuspid valve from pulmonary valve. And this is a continuation of the subpulmonary infundibulum, and as we trace further downwards here, this represents the ventriculo-infundibular fold, or the inner curvature of the heart, and on the epicardial aspect there's fatty fibrous tissue, and running within this groove is, as you can see here, the right coronary artery. So this seemingly huge chunk of musculature that we see separating pulmonary from tricuspid valve is in fact a folded structure of musculature, the ventriculoinfundibular fold. And this structure is embraced between two limbs of another muscular band or structure which is present or characteristically present in the right ventricular septal surface. And this is the septal marginal trabeculation, the body of it giving an anterior limb and a posterior limb from which arises the medial papillary muscle. And this septal marginal trabeculation, therefore, embraces within its limbs the ventriculoinfundibular fold, and the whole piece of musculature here in the normal situation, in the normal heart, represents the supraventricular crest. In the normal heart also, we would often find further trabeculations in the outflow tract that are called the septoparietal trabeculations. In the normal heart, these are fairly small and not hypertrophied, but they can become enlarged and cause obstruction in certain situations, for instance in hearts with Fallon's tetralogy. Now let's move on to another heart which can show us better. We have taken away the ventriculoinfundibular fold, and we are now able to expose the aortic valve. See, the aorta comes very close to the ventricular septum, and by removing the right aortic sinus or the leaflet of the right coronary sinus, we are able to get into the left ventricle, as I can see my probe passing through there. And by taking away the ventriculoinfundibular fold, we can show the cradling limbs of the septal marginal trabeculation across in this position, anterior limb and posterior limb here, with the body descending down towards the apex on the right ventricular septal surface. But what we can also see on this specimen, if we close up a little bit, here's the pulmonary valve. We have the subpulmonary infundibulum. Notice that? There's musculature there. And that's another continuation of the subpulmonary infundibulum. So it comes down here into this part of the right ventricular outflow tract. And I think this section also shows that the outlet septum, which is defined as a septum between the aortic and the pulmonary outflow tract, is minuscule, if not practically non-existent in the normal situation, because I can peel away the subpulmonary infundibulum, but I cannot, in this dissection, demonstrate a discrete structure which can be termed the outlet septum. Here's the leaflet of the aortic valve peeping through. Now coming back to the ventricular structures on the right side, just to go through a few things here. We have talked about the inlet portion of the right ventricle is the portion which receives the tricuspid valve and its apparatus. We have towards the apex of the heart the apical trabecular component, and we have towards the exit of the ventricle the outlet component. So when we're talking about malformations of the outflow tract, we would be describing structures which occur in this part of the heart which can cause obstructions to flow that leave the heart. we turn our attention to the left side of the heart and see what are the differences between the right ventricular outflow tract and the left ventricular outflow tract. And this section, which is a simulated parasternal long axis section, I think at the same time also shows the subpulmonary infundibulum quite nicely up here in the anterior superior part, with a small part of the pulmonary valve shown here, and pulling away on the subpulmonary infundibulum to demonstrate the musculature that supports the pulmonary valve on the right ventricular aspect. And there is a cleavage plane coming down here, and here is the musculature of the left ventricle, and here is the aortic sinus with the right coronary orifice in this position. Now we can see also that the aortic valve has very much more well-defined sinuses when compared to the pulmonary valve. So there are distinct bulgings at the root of the aorta, representing the aortic sinuses, and at the level of insertion of the commissure to the periphery, to the arterial wall, there is a waist-like appearance as indicated by the tip of the probe, so that we have a level described as the commissural ridge level, so that distinguishes between the sinus portion and the tubular portion of the aorta. Now the arrangement of the aortic valve is similar to that of the pulmonary valve, and there are again the three corresponding interleaflet triangles that are related to the spaces between the attachments, the semilunar attachments of the aortic leaflets. And if I just show a chart at this point, here we show the ventriculo-arterial junction laid out with the semilunar attachments of the arterial valve shown here, and the interleaflet triangles in green. And we can see that if we wanted to talk about the ring of an arterial valve, we might have to consider several options. One being the hemodynamic ventriculo-arterial junction, that is traced by the semilunar attachments of the arterial valve. Another being the sinutubular junction, that is a line or a level which can be drawn joining the apices of the three interleaflet triangles at the level of the peripheral attachments of the commissures. And thirdly, we can consider the anatomic ventriculo-arterial junction, which is the joint between ventricular musculature and arterial wall. So coming back to the left ventricular outflow tract, we find that the aortic valve has a feature which is not seen in the setting of the pulmonary valve, in that there is an area of aortic and mitral fibrous continuity, whereas on the right ventricular outflow tract there is a seemingly large chunk of musculature separating tricuspid from pulmonary valves. Now this curtain of aortic mitral continuity is shown here. We have, in fact, the aortic valve continuing into the anterior, or more appropriately described, the aortic leaflet of the mitral valve. And this shows also that the aortic outflow tract is sandwiched between the ventricular septum and the aortic leaflet here. So if I take another specimen and open up the left ventricle like a clam, we can see immediately, here's the aortic valve, here's the aortic outflow tract, and how closely wedged the aortic valve is into the deep central position of the heart. The outflow being limited on one side by the ventricular septum and on the other by the mitral valve. So there is an acute angulation in the left ventricle between inflow and outflow tracts. Inflow coming along and outflow going up in that direction. Now, having reviewed the normal situation, we'll look at the sorts of malformations that can affect outflow tract and that can cause obstructions to ventricular outflow. Now, ventricular outflow obstructions should be considered in terms of three levels: subvalvar level, the valvar level, and supravalvar level. If we take a chart, we can show these sorts of defects in the right ventricle that can affect outflow. Within the ventricular portion itself, there can be a trabecular obstruction or shelf-like structure at the apex or towards the apical portion of the ventricle that can restrict flow from inlet to outlet. There can be further obstruction at infundibular level. There can be obstruction at the valvar level. The valves can be malformed very frequently. In terms of valvar stenosis, the valve can be dome-shaped with a central orifice. Less frequently, we find a valve with three leaflets which are fused together, leaving a very restrictive orifice. But more usually, the valvar leaflets themselves are grossly thickened and dysplastic. Now, following the outflow tract further upwards into the pulmonary trunk, there can be ridges which present within the lumen of the trunk that can obstruct flow, or furthermore distally into the pulmonary arteries, there can be further restrictions to flow. We're coming to a few specimens just to demonstrate the sorts of, to give sampling of the sorts of malformations that restrict outflow. We have here a right ventricular view, and there's this situation which is seen in Fallot's tetralogy. In fact, this is a heart with Fallot's tetralogy, which will be a topic which will be dealt with in a later session. But it shows here the right ventricle opened up, ventricular septal defect, the biventricular connection of the aortic valve showing through the ventricular septal defect. Up here, going towards the pulmonary bifurcation, we note a rather small pulmonary trunk and a rather restrictive area of musculature just underneath the pulmonary valve. So we have not just pulmonary valvular stenosis, we have here a two-leaflet pulmonary valve, but we also have musculature underneath the pulmonary valve supporting the infundibular portion that is restrictive. Part of the musculature has been taken away in this dissection, but we can see the characteristic hallmark of Fallot's tetralogy, the anterior calf-flat deviation of the outlet septum, which has squeezed the subpulmonary outflow tract forwards up in this direction. This further narrowing of the flow of the outflow tract due to hypertrophy of the septomarginal trabeculations. There is also in the ventricular chamber itself an hypertrophy of the septomarginal trabeculation. The body of the septomarginal trabeculation, you can see here, is quite thick, as is the moderator band crossing the chamber cavity, and these are the sites of ventricular outflow obstruction in this particular heart. I have said that in the normal heart, the outlet septum is not a distinguishable structure, but in hearts with a ventricular septal defect, as in this case with Fallot's tetralogy, the outlet septum is a very well defined muscular structure, which gives the characteristic hallmark for Fallot's tetralogy, for the outflow tract morphology of the heart with Fallot's tetralogy. In this case, it is also hypertrophied, and it separates the pulmonary valve up here from the aortic valve behind it. Coming to another situation with right ventricular outflow obstruction, we're looking down a fairly small heart, but we're looking down into the right atrium on one side. Here the right atrium. The tricuspid valve, as you can see, is slightly dysplastic with thickening of the edges, and as we come down towards the apex of the heart, try to open up the heart a bit more, we can see that we cannot quite get into the apical portion of the ventricular chamber. So if I go towards, turn the heart round a bit, and go towards the outflow tract, here I have the probe in the outflow tract, we're approaching the pulmonary trunk, and I try and open it up without destroying the heart too much, and try and get some light into it. Right, I think we're nearly there. Here, can you see that? We have at the tip of the probe is the communication between the inlet portion and the outlet portion of this right ventricle. Up here at the apex, at the ventricular apex, is a shelf of muscular tissue that is separating the inlet portion from the outlet portion. So the only communication between inlet and outlet is through this aperture, behind which is the anterior superior leaflet of the tricuspid valve, and up here to the pulmonary trunk. So we have a two-chambered right ventricle in this situation, which is causing obstruction to outflow. If I remember correctly, in this heart we also have small left ventricles, and it also was associated with a two-leaflet aortic valve. Quite a small ventricular chamber here leading up to the aortic valve. Try another heart. Again, quite small. And we see up here we have a very thick-walled right ventricle. We have a small tricuspid valve, but nonetheless, but patent. And leading upwards here, we have a thickened pulmonary valve. Leaflets very thick. We can't quite get the camera close enough, but the commissures are fused at near towards the periphery, so we have a very dysplastic pulmonary valve with a tiny orifice in the middle. It has 3 leaflet configuration to begin with, but it seemed as if there was too much fusion of the leaflets along the commissures. Now coming to the left side of the heart, we can see that this is a heart which has had quite a lot of surgery on it. It has had, previously it had interruption of the aortic arch repaired across there. We look into the left ventricle and we see that it has ventricular septal defect, the aortic valve coming up here, but there is deviation of the outlet septum into the left ventricle, which has squeezed the aortic outflow tract. The deviation of the outlet septum, either into the right or into the left ventricle, will consequently give obstruction to ventricular outflow, as shown in this heart. Now, ventricular outflows can also be associated with malformations of ventricular arterial connections, as we see in this heart. We have a situation with complete transposition, the aorta coming off from the right ventricle and the pulmonary trunk from the left ventricle. And opening up the left ventricle, we can see a sort of bulging of the ventricular septum along there, which has caused this time subpulmonary outflow obstruction instead of subaortic outflow obstruction. There is a bulging of the ventricular septum that has restricted the outflow between the mitral valve here. Mitral valve is also very, very dysplastic, so there's some further restriction of flow, it seems, in this left ventricular chamber. Now, when we talk about left subvalvular obstruction, we often find descriptions of subaortic stenosis referring to subaortic membranes. Well, we show here one of these cases to demonstrate what is the anatomy of this membrane. So we can see the mitral valve here, the aortic outflow here. I'm trying to get my probe up into the aortic valve, and in the subvalvular area, the area that is just underneath the aortic valve, we see very nicely a ridge of fibrous tissue that is forming a shell lesion that's occluding flow to the aortic valve. And this ridge is better described as subvalvular shell rather than as a membrane, because it is usually fairly thickened and not very pliable, as one would expect a membrane to be. Now moving along the left ventricular outflow tract. Here's another heart, another specimen. And this I'm showing also a septal bulge. restricting flow to the aortic valve. It has been sectioned in such a way that resembles a peristernal long axis section, showing quite nicely the bulging septum in association with hypertrophic cardiomyopathy in this situation. There are other structures which can obstruct ventricular outflow, and these are aneurysmal tissue tags. They may be accessory valvular tissue tags. In this case, an aneurysm of the membranous septum, which is popping in and out here in this position, just underneath the aortic valve. Now the aortic valve itself can be stenotic. So when we talk about outflow obstructions, consider also the nature of the valve. The aortic valve here is very much thickened. It is two leaflet configuration, but very thick and not pliable at all, giving aortic obstruction. The bileaflet aortic valve in most situations has been described as being non-obstructive, usually in children, but in people of the 70th or 80th decade, they can go on to become calcific and later become very, very non-pliable and become severely stenotic. In this case, this is a child part from a teenage person, and yet the valvular tissue itself is not calcific, but is very much thickened with dysplasia. Now moving to another heart, and this just to show another situation where again the valvular leaflets, this time the aortic valve leaflets, seem to have very deep pocket-like arrangements, and this has produced a situation which is sometimes described as supravalvular aortic stenosis. We can see this very clearly, this clear indentation or wasting at the level of the aortic valvular commissures, giving, as we've said, a situation usually described as supravalvular aortic stenosis. But examining it closely, it is actually at the level of the commissural attachment of the aortic valve. So it is, to be precise, also a form of aortic valvular stenosis. Now this heart is further associated with isolation of the right coronary artery. In this case, the right coronary artery comes in here, enters the aortic sinus, but the aortic valve is so malformed and dysplastic that this leaflet, the right leaflet, was completely plastered against the wall of the aortic sinus, excluding the right coronary artery from the circulation, apart from a tiny little aperture at the middle portion of the valve leaflet here. So to summarize, we show a chart of malformations in the left ventricular outflow. These substrates of outflow obstruction can be due to anomalous insertion of valvular apparatus, such as extra leaflet tissue or cords crossing the outflow tract. Can be due to septal hypertrophy, can be due to a shelf or tunnel type of lesion, can be due to valvular obstruction due to malformation of the valve itself, or supravalvular, so-called supravalvular obstruction. Now the types of obstructions within the aorta itself varies from the hourglass type, where there's a distinct wasting at the level of the commissures, to a membranous type, where there's a membrane with a central aperture, or there's a tubular type, where there's diffuse hypoplasia of the ascending aorta. So malformations of the outflow tract can be considered in terms of subvalvular obstructions at the level of the valve, and finally obstructions distal to the arterial valve. Well, the topic for this afternoon is malformations of the atrioventricular valves. And to understand malformations of the atrioventricular valves, we need to consider the normal structure of the atrioventricular valve, which is composed of the hinge point forming the junction between the atrial myocardium and the ventricular myocardium. And from the hinge point drapes down the leaflet of the atrioventricular valve. Then there are the tendinous cords, or cordi tendini in old money, that's attached to papillary muscles which support the whole valve structure. So for normal functioning of the atrioventricular valve, it requires a harmonious action between all these various parts which make up the valve. The valve can be considered in terms of functional aspects, or malformations of the valve can be considered in terms of functional aspects. And to understand the functional aspects, we need to understand the morphological variations. And what I'm going to show you this afternoon are mainly valves which are congenitally malformed rather than having acquired valvular disease. So to begin with, we first look at the normal tricuspid valve. Here is a heart which you are quite familiar with. I think you've seen this heart many times. We have taken away the free wall of the right heart, just to show right atrium here, right ventricle, with the apex for orientation. We're left with the septal leaflet of the tricuspid valve, and it is septal in that it has caudal attachments directly to the ventricular septum. So I lift up the strands, of course, with my probe here. There. So the septal leaflet, with its direct caudal attachment, is a good morphological marker for a tricuspid valve. We follow the septal leaflet along its hinge points there. We can see it coming across and crossing the area of the membranous septum. Can you see that area here, which has a somewhat different coloration from its surrounding structures? This grayish area is the area of the membranous septum. Now to turn our attention to another heart which shows the tricuspid valve more in its full glory. Here we are, the whole structure spread out. Right, we display the tricuspid valve to show not only the septal leaflet here, with its caudal attachments to the septum, but also the continuation of the septal leaflet across to the continuation with the anterior superior leaflet here. Here's the commissure between the septal leaflet and the anterior superior leaflet. And this commissure is supported by the medial papillary muscle down here. So we can see that the septal leaflet is not entirely confined to the septal part of the heart, but comes across, crosses the membranous septum and swings up the front part, the anterior part of the insertion point of the valve. And following back round the corner, we have the entirety of the anterior superior leaflet, and then there is the posterior leaflet. Now coming to the left atrioventricular valve, the mitral valve, let's look at this specimen from above, and we can see the arrangement of the leaflets of the mitral valve. There is the aortic leaflet that is closest to the aortic valve, and there is the much more crescentic shape of the mural leaflet, which extends along a wider circumference of the mitral valve insertion than does the aortic leaflet. The aortic leaflet, on the other hand, is much deeper in dimension from there to there than the mural leaflet. We see the two commissural points of the mitral valve. There are, you will note, several scallops to this mural leaflet. They range, they vary a lot, usually 3, sometimes 4, 5, or as in this heart, rather indistinct, but seems to have several scallops involved there. The support to the mitral valve is confined to 2 papillary muscles. Here we see them in diagonal arrangement. When we look at the cross-sectional arrangement, the papillary muscles are in fact fairly close together. We look at the mitral valve from below on this heart, on this normal specimen, and we see the arrangement of the 2 groups of papillary muscles, here and here being the inlet, the orifice of the mitral valve coming in through here. And so flow has to come through in this direction and passing through the intercaudal spaces and underneath the aortic leaflet to get back up towards the aortic valve there. So we see the arrangement of the atrioventricular valves, a rather complex structure comprising the papillary muscles, the tendinous cords, the leaflets, and the hinge point of the valvar leaflets. Now coming to the various malformations of the atrioventricular valve, they can occur at various sites of the valve, for instance, at the annulus or the hinge point, at the level of the leaflets, or further downstream at the level of the cords, the tendinous cords. There may be occlusion of the intercaudal spaces, or in the arrangement of the papillary muscles. Now some of these lesions, in fact, affect not just one part of the valve apparatus, but affect a combination of the various structures. At the level of the annulus, there would be the most easily seen malformation would be across the atrioventricular junction there, and this is an example of an imperforate atrioventricular valve, which is the tricuspid valve sitting on the right side. Here's the ventricular septum, a very small right ventricular cavity. The papillary muscles themselves are also not well developed, so an imperforate tricuspid valve in a setting, in this case with hypoplasia of the right heart. But an imperforate valve needs to be distinguished from absence of the atrioventricular connection. In this case, we can clearly see the valvar membrane interposing between right atrium on this side and right ventricle on the other side. And here is the atrioventricular groove tissue that interposes between atriomyocardium and ventricular myocardium at the parietal junction. The imperforate valve needs to be distinguished from absence of the atrioventricular connection. In those cases, the imperforate membrane is missing and the groove tissue making up the atrioventricular groove, is much more extensive and extends underneath the muscular floor of the atrium across in this direction, thus occluding completely the outlet from the atrial chamber. Another malformation which can affect the annulus, or at the annular level, is that of straddling and overriding of the valvar orifice. We have here a 4-chamber section showing the atrial septum and ventricular septum here. Ventricular septum is aligned in that direction, whereas the atrial septum is in this direction, and therefore we have malalignment between the cardiac septums, leaving a ventricular septal defect in this position and the tricuspid valve straddling across the top of the ventricular septum to insert into a papillary muscle in the left ventricle. Straddling describes the situation where the tension apparatus is inserted into both ventricular chambers, like in this situation, whereas overriding of the valvar orifice, which is what you also see in this heart, that is one extreme of the valve orifice, tricuspid orifice, and that is the other extreme of the valvar orifice in this 4-chamber section. And you can see that the right atrium here opens to the left ventricle as well as opening into the right ventricle. And by this is described overriding of the valvar orifice. Overriding and straddling usually coexist, but you can also have situations where there is pure straddling or pure overriding. Now, overriding of the valvar orifice can change the type of atrioventricular connection you have. If you remember from one of the earlier talks when we went through a sequential segmental analysis, the commitment of the valvar orifice to the ventricle can determine the type of atrioventricular connection you have. In this instance, as we can see, there's only a little bit of the valvar orifice that is committed to the left ventricle, and so this heart still has a concordant atrioventricular connection. But the atrioventricular connection changes to that of double inlet left ventricle if this orifice shifts more and more across the ventricular septum to be committed by more than 50% to the left ventricle, and therefore you get a univentricular atrioventricular connection instead of a biventricular atrioventricular connection. And similarly, if you have a mitral valve that is straddling, or a left atrioventricular valve that is straddling, it can change again your atrioventricular connection to that of double inlet right ventricle with a rudimentary and usually hypoplastic left ventricle. Now the tricuspid valve, when it straddles, has implications for the disposition of the conduction of the atrioventricular conduction axis. So you can see here the posterior insertion of the ventricular septum is deviated away from the area of the heart that we describe as the cardiac crux. Here's the area of the heart that is described as the cardiac crux. It's right at the back of the heart, and here we have the mitral valve originating, and here we have the tricuspid valve originating. So we expect to find the regular atrioventricular node situated in this position of the heart, very close to the area of the cardiac crux. And I can just about get my probe into the coronary sinus. But this is not the case in this heart, because the connecting atrioventricular node and the penetrating bundle is deviated away from the crux of the heart towards the right side of the tricuspid valve orifice. It is in this position where the posterior inferior margin of the ventricular septum inserts into the atrioventricular junction. So a very important consideration for the surgeons when approaching a heart with straddling or overriding of the orifice of the tricuspid valve. Now coming to the other side of the heart, overriding and straddling can also affect the mitral valve, and this is often seen in a setting with double outlet right ventricle. In here we see the right ventricle of this heart giving rise to the pulmonary trunk as well as the aorta, and down here we have the ventricular septum with the tricuspid valve on this side, and you see attachments of the mitral valve inserting into the right ventricle across the ventricular septal defect way back here. Now if I turn the heart round to the left ventricular aspect, open up the mitral valve, we can see one papillary muscle here. We can follow through the valvular leaflet as it crosses over through the ventricular septal defect to the right ventricle. Here we just pick up some tendinous cords in front of the probe, inserting to a papillary muscle in the right ventricle. In the situation of straddling of the mitral valve, it occurs across the anterior part of the ventricular septum, whereas in the case of straddling of the tricuspid valve, it occurs usually at the posterior part of the ventricular septum. It's a ventricular septal defect that usually affects the anterior part of the septum rather than the posterior part. So, double orifice with straddling. Well, this is a double outlet right ventricle with straddling of the mitral valve, but this valve has only one orifice. The second orifice is probably formed by a fusion of a tissue tongue between the two valvular leaflets. Very occasionally you would come across cases of duplication of the mitral valve where you have two valvular orifices with two sets of tension apparatus, but that is a rarer variant. Now coming to another situation which affects the valve leaflet, we have a lot of hearts here which demonstrate this particular anomaly, and this is Epstein's malformation. Epstein's malformation most commonly affects the tricuspid valve. There have been a few reports of the Epstein's malformation affecting the mitral valve, but they're very rare. Mitral meaning, I hope morphologically, mitral valve rather than a left-sided atrioventricular valve. If it's affecting a left-sided atrioventricular valve, it is more usually in the setting of congenitally corrected transposition, as we have in this heart specimen. The right side of the heart opening through the mitral valve to a left ventricle, whereas on the left side, a morphologic left atrium, opening through the tricuspid valve to a morphologic right ventricle. This tricuspid valve recognizes the attachment of the septal leaflet to the septum. The tricuspid valve is plastered down into the depths of the ventricle, and the anatomic description of Epstein's malformation is that of a displaced and apically displaced attachment of the valvar leaflets, affecting especially the mural and the septal leaflets. So we have on the left side a tricuspid valve with Epstein's malformation. But more often it is a right-sided valve that has the Epstein's malformation. In this rather large heart, the holes in the septum are artifactual. It perhaps shows where not to cut across the heart. And the heart is cut across right through the septum, creating artificial ventricular septal defects. But if we can back off the camera a little bit, we can see, let me try and get orientated. We have a rather smooth junction across here. This is the coronary sinus, and therefore the right atrium here to the left side, and right ventricle here to the right side. This being the level of the atrioventricular junction where the probe is lined up. And what we can see is that there is a displacement of the valvar insertion way down into the depths of this ventricle. Here we can see, if I hold this up, that this is actually ventricular myocardium, but it is considerably thinned, and this is described as atrialization of the right ventricle. This malformation is due to, or this Epstein's malformation is due to a lack of delamination of the leaflets that make up the tricuspid valve. That is, the leaflets have failed to come off from the ventricular wall to give you proper functioning leaflets. The leaflet that is most affected is the mural leaflet. As you can see here, it has not formed itself or lifted itself off from the myocardium. It's totally plastered down onto it. This, sorry? On the right. It is a malformation of the tricuspid valve most usually. The posterior leaflet, if you like. Right. And also the septal leaflet is plastered down, and in this case there is a sort of cauliflower type of appearance of the remnant of the septal leaflet that I can just about lift off from the septum.